Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hi, everyone. Welcome. My name is Chen, Physician Director of Practice Sustainability here at the AMA. On today's podcast episode, I'm joined by Dr. Richard Kovacs, Chief Medical Officer for the American College of Cardiology. Welcome, Dr. Kovacs.
Good to be here.
Let's start off with talking about the American College of Cardiology, the ACC, recently joined the AMA's Behavioral Health Integration Collaborative, a group dedicated to catalyzing effective and sustainable integration of behavioral and mental health care in physician practices. Dr. Kovacs, before we dive in, could you share a little bit about yourself and your background with our listeners?
Well, first, again, thanks for having me. I'm a cardiologist and I've been practicing almost 40 years now. I practice at the Indiana University School of Medicine where I'm a professor, but I have been engaged with the American College of Cardiology through my entire professional career. And just to orient a little bit about the ACC, so the ACC is the professional society for the cardiovascular professional, specific to the United States and increasingly around the globe. About 26,000 practicing cardiologists in the United States, and 95% of them belong to the ACC. So we are the professional society that represents cardiology. I've served as the president of the college from 2019 to 2020. A couple of years ago, I accepted a position as its chief medical officer, sort of a staff level position within the college to coordinate efforts like the AMA's Behavioral Health Initiative.
Great. Thank you for that introduction. That really gives us context in how you're going to be talking about these issues today. Dr. Kovacs, why do you think the integration of behavioral health is important to cardiology?
Well, behavioral health is important to all of the patients that we serve. And when we were approached by the AMA about becoming a part of the collaborative, we started to explore and talk within our membership about the role of behavioral health in the care of the cardiac patient. Number one is we all recognize that cardiologists, we care for a chronic disease in many cases, coronary disease, heart failure, congenital heart disease. We're caring for patients over a continuum. And so these patients face behavioral health challenges throughout that continuum of care. The second thing that we discovered is that cardiology is a very specialized specialty. It's not a monolith. We have folks that are caring for patients who have heart failure, who need a transplant. We have cardiologists who are caring for adult congenital heart disease patients who have a lifelong journey of cardiovascular issues. We care for patients through acute illnesses like heart attacks who come out depressed. We care for patients with infective endocarditis who have substance use disorders. We have smokers. It's not a single state. And as we began to socialize this within the ACC, we learned that every cardiologist has a little different view of this, but each one seems to have a consensus about the importance of this in the care of our patients.
I think you've highlighted very nicely that there's a wide breadth of patients that you take care of, and for an extended period of time. It's not just the primary care physicians that take care of patients for over a long period of time. It's all specialties, and especially in cardiology, we can definitely see that, and there's a huge variety of patients. I know that you've given us a few examples of how behavioral health impacts your patients. Do you have any examples of where you've seen behavioral health care impact your patients in a meaningful and uplifting way?
Yeah, absolutely. I see this daily, but I mean, one area in which we as a system came together was with care of patients with infective endocarditis due to intravenous drug use. As we all know, but I'll just review, these patients are sick to begin with an endocarditis. They have very high recidivism rate. Substance use treatment and participation by our addiction medicine specialists is a key part of their care. In my own institution, we put in place an order set. an automatic order set to involve addiction medicine and provide holistic care for those. And I've seen it personally with several patients who have been very, very receptive to this. Lower recidivism rates, lower stress on the healthcare system, lower coming back for their second or third valves, lower stress on our nurses. So that's been very gratifying. The day before yesterday, I saw a post-infarction patient, though, who was depressed. Yesterday, I saw a patient needed bypass surgery. About a half an hour after he left the office, he called me and said how anxious he was now about an impending major surgery, reaching out for help, which leads to a little bit to to a little bit of frustration on my part that for the depression and the anxiety, I didn't have the embedded solution. So we're working toward that, but we see these people every day.
In terms of your members in the ACC, what kind of challenges, pitfalls, or insights have you heard from your members when it comes to integrating behavioral health and behavioral health care in their practices?
First and foremost, it's going to be recognizing that cardiology is not that monolith and adapting the behavioral health care to the particulars of the practice. The needs of the advanced heart failure clinic and the transplant patient or the patient who has an implantable LVAD is going to be different than, as I mentioned, the patient who comes after an infarct and is suffering from depression, or the patient who has an implantable defibrillator and the defibrillator goes off and then they have what amounts to PTSD, worrying about that next shock and how they can go on with their life. So I think one of the biggest challenges in cardiology is going to be tailoring the availability of behavioral health care to the particular needs of those patients.
Have you heard any members having some wins, if you will, in the space, and how have they sort of facilitated that integration in a very smooth and effective way?
I was talking to somebody who takes care of adult congenital heart disease. They've had great success. One is having a resource, having a psychologist that's available. Number two, having them embedded within the team and truly part of the team. And the third, the success was also based on that we call, I guess, a warm handoff. I'm your cardiologist, but I sense that you're having a problem, and here's a member of my team that I'd like to help you address this problem. It requires a lot of collaboration and team care. It requires having people readily available. It requires reinforcing that behavioral health is part of your cardiac care. But when you have those components, you can be highly successful.
I think you've just highlighted quite a few items and issues that our collaborative is trying to get through to its members, our behavioral health collaborative, these concepts of team care and warm handoffs. And so I think that's a great example of it. We obviously hear a lot about sort of the lack of resources, the shortages in clinicians, behavioral health clinicians. So we're all working towards trying to figure out how to wade through those difficulties for sure. So in terms of whole person health, so both behavioral health and physical health, where would you like to see cardiology as a field sort of get to? What do you see in the future? What would you like to see as an optimal state?
Well, I guess I'll use the analogy that unfortunately much of what we're doing is we're mopping up the floor of the proverbial overflowing sink. And where I'd like to see cardiology go is to start to turn off the tap that's causing the sink to overflow in the first place. That sounds trite, but I think it's quite true. Something as simple as help with smoking cessation to prevent the problems in the first place, to address these issues up front, to bring greater value to what we do is the future state. And having these services available is key. And realize that day after tomorrow I may be driving 40 miles to an outreach clinic where I don't have the same resources to serve patients in a rural environment that I would in an urban environment. I'd like to see this truly embedded, truly getting at the root causes, truly helping us with managing the whole person and the whole disease state, and embedded really into primary prevention of cardiovascular disease.
Hopefully, we in the behavioral health Integration Collaborative are doing these sorts of advocacy pieces to try to move from treatment to prevention a little bit more than we are now. So in terms of the ACC, what do you hope to gain from joining the Behavioral Health Integration Collaborative? Are there priorities that you all would like to see happen as a group?
I think probably on three levels. Number one is tapping in to what the AMA has already done. I mean, there's a very rich, I'll call it a library of tools and information on this. And I think that, again, in my own institution, I'm leaning on the experience in primary care where we've had very strong advocates for universal availability of behavioral health care and consultation and advice within the primary care environment. So I think number one is the college is going to take advantage of what's already been done and adapt it to the care model that we have as specialists. I think the second thing that we hope to get on this is, again, building on the foundation and adapting those care models and using the bully pulpit of the AMA to get this out to our members that this is important, because I'm an advocate for this, but busy clinicians seeing the volume of patients, doing the volumes of procedures that they are doing. We've all heard this. Let's just do one more thing. Let's just add one more little bit to your day, one more phrase to your note, one more item in your inbox on the electronic health record, and then you'll start to see the hair being pulled out. So how do we truly embed this? And then third is learning also for advocating for this and advocating for how we can provide these services under the current payment models to make this feasible in the practice, to make these resources. This is going to have a cost. That cost is going to have to be balanced out, as we all know. It's going to be balanced against somewhere where there's going to be savings, and hopefully that's from proof of value of this. But I think having a sustainable model for payment in this area will be a third component.
I think you outlined the need for sustainability very well. I think that that's one thing the collaborative is working on very much so at this point in time. We know that a lot of these programs, these ideas will cost money in the short term, but in the long term, these hopefully will bear fruit in terms of patient outcomes and even decreases in cost. As we talked about before, I think the prevention piece will hopefully decrease some of these downstream costs. But I think we as a collaborative need to make the case to the stakeholders, the payers, et cetera. So I think that that's absolutely imperative that we do. In terms of, your membership, have you heard of anything that they're asking for in terms of help with behavioral health integration? Hey, we need this and we need it now, or we need it in the near future.
I think clear pathways for care would be very helpful as well. Cardiology, the ACC has been very active in the development, not only of guidelines, but of expert consensus decision pathways that are not necessarily a guideline per se, but a path forward. And in this area, we're completely devoid of that. Similar to pathways that we have. I mean, we have a smoking cessation pathway, for example, an expert consensus decision pathway on smoking cessation, but we don't have one for management of the post-MI depressed patient, or as I said, the patient who's had an ICD shock and is really worried about the next one, or those more deeper seated issues with the long-term care, like I said, of heart failure or adult congenital heart disease. So I think those would be very, very helpful to have in the near-term future.
Thanks for that insight. When we talk about you all joining the Behavioral Health Integration Collaborative, we're looking for fresh ideas, especially because we've extended the collaborative to include non-primary care specialties. Do you have, from your perspective or from the ACC perspective, any insights or wise words of wisdom for other folks who are specialists who want to get into this space, who want to integrate behavioral and mental health care into their practices, into their patient care? Obviously, we're all walking this journey at different phases, but from your perspective, what are those insights? What are those words of wisdom on how to start or how to continue?
The one bit of wisdom, if I if I can be so bold, is throw your preconceived notions away. Don't be afraid. This is the right thing to do. I'll give you a parallel example, not in behavioral health, but cardiologists are increasingly metabolic doctors. SGLT2 inhibitors are widely applied now across our heart failure population, and not so many years ago, 3 years ago perhaps, we're saying cardiologists, we're not diabetes doctors, we're not managing your blood sugar, but one of our primary disease states, coronary disease, is an incredibly metabolic disease. So don't be afraid. Put your toe in the water. Start to get familiar with this. This is part of how we care for our patients, because we are all linked together. As I mentioned, we have cardiometabolic and cardiometabolic aligned with the kidney, and so we have to integrate with the other areas, and behavioral health is just one of those areas that we have to integrate with. So don't be afraid.
Those are indeed wise words. Fear sometimes drives us not to do things that we know we need to do. So whole person care is definitely critical to all of our patients. Do you have any final thoughts that you'd like to share with our listeners, and your thoughts on the ACC joining the Behavioral Health Integration Collaborative?
Well, I mean, we're grateful. We don't have all the answers yet. We're gonna work through this, and I think most importantly, we're gonna be humble and recognize all the good work that has been done and try to learn. So I think cardiology, we're going to be watching and learning and testing and tweaking, and we're very grateful to be part of this. But we don't have all the answers. I'm not sure we have answer one yet.
Well, thank you so much for joining us today, Dr. Kovacs. Listeners can find out more about the AMA's Behavioral Health Integration Collaborative in the episode description.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.